Fast bone formation in implant dentistry is often presented as a positive outcome. Bone appears early, radiographs look reassuring, and the healing seems uncomplicated. But with experience, it becomes clear the speed in biology can be misleading. In implant surgery, bone can form before the system is actually ready to use it. Implant mastery is not about better hands, it's about understanding how the body responds to every decision you make. After 30 years in surgery, I've learned the biology drives success. This channel explores implant and oral surgery, how the body responds, how it can improve healing, and how disciplined surgical execution turns evidence into results. Today, we're talking about when fast bone is the wrong bone. The issue is not that grafts resorb. The resorption is expected and necessary. The real problem is timing. Bone regeneration, angiogenesis, implant stability, and load tolerance all follow different biological timelines. When graft resorption runs ahead of biologic stabilization, the system becomes vulnerable even if early healing appears ideal. Bone formation is an early event. Mechanical competence develops later. Vascular maturity develops later still. If volume is lost before these processes are established, the implant is supported by bone that exists histologically but is not yet functionally reliable. This mismatch is easy to miss because early indicators are reassuring. Radiographs look good. Soft tissues appear stable. There may be no pain, no infection, and no obvious complication. However, bone that looks mature is not necessarily capable of tolerating load, remodeling pressure, and time. Failures related to timing do not announce themselves early. They emerge months or years later, often attributed to occlusion, hygiene, or patient factors, while the underlying biological sequence is overlooked. Fast bone formation is not the same as stable bone. Implant success depends on matching the rate of graft resorption to biologic readiness and mechanical demand. In horizontal ridge augmentation, space must be maintained long enough for cortical organization and structural continuity. If resorption occurs before this process is complete, relapse is likely regardless of surgical precision. In thin buccal phenotypes, early resorption affects not only hard tissue but also soft tissue stability. When support is lost too early, contour changes follow and aesthetic compromise becomes difficult to reverse. In early or progressive loading protocols, bone may be present but not yet competent. Mechanical demand increases faster than the tissue's ability to respond, leading to gradual destabilization rather than immediate failure. In patients with high inflammatory burden or oxidative stress, biology is already operating under constraint. Fast resorbing grafts widen the timing gap further and reduce the margin for recovery. Complete graft turnover is often described as an ideal outcome. In reality, this is a histologic concept rather than a functional one. Implants do not require bone that looks perfect under a microscope. They require bone that can maintain volume, tolerate load, and adapt to remodeling forces over time. Prioritizing speed over stability often produces impressive early images and disappointing long-term outcomes. The goal of grafting is not permanence and not rapid disappearance. The objective is controlled persistence. A graft should remain present long enough to maintain space, support vascular development, and protect the implant-bone interface until the system is capable of carrying load independently. Timing rather than speed determines whether regeneration is durable or transient. A technician focuses on how quickly a graft turns into bone. A biologist considers whether the graft continues to serve its purpose when mechanical and biologic demands increase. This difference in perspective explains why identical materials can produce predictable outcomes in one clinician's hand and inconsistent results in someone else's hands. Fast bone is not always strong bone. When resorption outpaces stabilisation, regeneration becomes fragile. Biology does not reward speed, it responds to timing. If you're an implant dentist who wants biology-driven complication-proof surgery, please subscribe. Every week, we break down one clinical problem you've already seen in your practice. Do you choose grafts based on speed or based on timing? Comment below.